excuse me, if anybody has looked at the syllabi, or syllabus actually, I should say, we are doing what they call computers in radiation. So what is the main use of computers in radiation therapy? Anybody?
Treatment?
A little more specific than just treatment?
Or like the treatment planning would be on there.
No, we're not talking about treatment planning, we're talking about actual treatment. But you're in the right
like
vein.
the program
Yeah.
is on the computer.
The program that we use to what is called Record and Verify, or R&V, or VNR, whichever way you want to say it, is the main computer program that we use. But what else does the Record and Verify or the software do apart from run the machine and run the treatment? Anybody, any ideas? How do we schedule patients? How do we tell the patients when to come in? That's done by computer, and that's usually included in the Record and Verify system. There's also the bugbear of everybody in healthcare in the US, billing. That's also a lot of times included in the Record and Verify. So those are the things that we use computers with. Apart from the fact that we can also do other things with computers, like search the internet, things like that, which of course we're not supposed to do, right? And we're working. So we are going to look, and I know we've been through this before, but I'm just going to run through a little bit of it. So this is chapter 24 in your books. Which is called Electronic Charting and Image Management. Now, I know we've done through this before. Does anybody remember doing this? No? Yes? Okay, good. So this will be a review. Right? So, electronic charting. Medical records, EMR. Electronic medical records. So everything that the patient needs to have done should be included in the medical record, right? Maybe. The MR is the medical record for the general health of the patient. In some departments, the Record and Verify, which is the computer that runs the machine, and the medical record, the EMR, are the same. Sometimes they're different. Because if you're in a hospital, your EMR will be from the hospital. And you have the record and verify system for the department. They could be totally separate and they may not talk to each other, which causes a problem because then you have two computer programs that you have to work with. And it's not so bad if it's an outpatient, because then all you need is a record and verify in the department. But if it's an inpatient, then you have to do some patient care notations in the hospital-based system. The biggest hospital-based system is something called Meditech. Anybody ever heard of that? No? Take it from me, you never want to hear about that. It's a terrible system. It's been going since at least the 1970s, to my knowledge. And it was, and you know what I mean by DOS? She's nodding her head.
Wasn't that the original starting systems for computers back in the dinosaur times?
Well, the 1970s, yes. Yeah, DOS was a system which ran the computers before Windows or Linux or any of the others came to pass. So unfortunately, Meditech still works in DOS. So if you have to use it, it takes a bit getting used to, but it's still very weird. So there are two, what we are concerned about is the EMR that is functioning, or the the record and verify, which is functioning as a radiation therapy EMR. That's what we are concerned about. There are two main types of record and verify. One, which is for Varian machines, usually. And the other one, which is for Elekta, usually. They can be superimposed in each other. The Varian one is called ARIA, A-R-I-A. And the Elekta one is called Mosaic. And that one is M-O-S-A-I-Q, I think. That's what it is. So you have either one or the other. Now, I'm not saying that if you have a Varian machine, you have to do ARIA. You don't. But the Varian systems work better on ARIA. However, you can use Mosaic, and some people do. It just 6 of one, half doesn't matter. So the EMR that works as, or the record and verify that works with the EMR does all sorts of things. It will give you the demographics of the patient. What kind of things would the demographics give you?
Soap
If-
notes,
Pardon?
soap notes, your history of the patient, the family
Well,
history.
no, actually, no. Demographics is not
Like
history of the
age?
patient.
Like age, race.
Yeah, name, address, phone number, age, next of kin, that type of thing.
I've always lumped that all together.
Yeah, well, that's the demographics. And then you have what they call the history and physical, which is the past history of the patient, past medical history of the patient, right? And in that history, you have medical history, you have social history, you have personal history. So medical history would be what's been wrong with the patient. Have they had any medical history? Have they suffered from any diseases in the past? Do they have, what kind of disease do they have now? Do they have lung cancer, breast cancer, whatever cancer? The personal history would be what age they got cancer, when were they diagnosed, etc. Social history would be family history would be, are their parents alive and well? If they're not, what did they die of? Grandparents alive and well? If not, what did they die of? Do they have anyone who has had cancer? Do they have cancer in the family before? If so, whom? And what kind? And did they die of it or die with it? There's a difference, right? You can die of breast cancer. You can die with breast cancer. Prostate cancer. Most men who get prostate cancer will die with prostate cancer. Majority of them will not die of it. That makes sense? Okay. So let's see what we've got here. EMRs allow many caregivers to follow a patient. So you don't have to run around looking for a chart for the doctor. He can go onto his computer and get the chart up and do what he needs to do then. Is there something wrong with that though? Is there any side effects, or not side effects, but is there anything that is possibly,
If the network's down or if the
well, if the
system
network's
crashes.
down, you don't do anything, right?
Or the system crashes.
Yeah. So if your radiation oncologist is doing something in the patient's chart, and the surgeon comes in and says, "Nah, I need to do something on this Mrs. whatever her name's chart," and he brings it up and he does something, and he orders tests, for example. And meantime, at the same time, the radiation oncologist is looking at the chart and he orders imaging as well. So they may be ordering the same image or the same imaging series. And they're both doing it together. So you don't see because they're both doing it at the same time. So if they went back in, they would see it. But at the moment, they're doing the same thing at the same time. Is that a drawback? Yeah. I mean, that means that the radiologists or the X-ray tech or the person who is actually booking the imaging calls the lady and says, "You need to come in, Dr. So-and-so's ordered," whatever. And then she looks down and she sees another one and she's thinking, silly idiots, who've done it twice. But it's a different doctor that's done it twice. That's a drawback. Whereas if you had a paper chart, the radiation oncologist could do his thing, but the surgeon would have to wait for the chart to come to him in order to fill in, and then he would see, oh, he's ordered that, so I won't bother. Not that I'm saying the chart is better. I'm not. There's a lot worse things can happen with a paper chart than there is with an electronic chart. Give me an example of something that can happen with a paper chart that can happen with an electronic chart.
They can get lost.
They can get lost, yes. Yeah, it has been known for charts to get lost. They're not actually lost, just somebody has them and doesn't tell anybody. But yeah, charts can get lost. Anything else?
They take up a lot of space.
Yep. That's right.
Can't read handwriting.
That's the one I was waiting for. Doctor's handwriting is notoriously bad. So you have a chart to look at, and you look at this handwriting, you think, what the heck is he talking about? And you read it, and you read it again, and you go to the doctor, and he looks at it and says, I don't know. I had somebody do that to me at one point.
Is there a reason, like a scientific reason that doctors handwriting bad?
I heard, or I read that it would, like, if your handwriting's bad, you're like notoriously smarter or something.
Yeah,
I don't know if that's like true.
it's not.
You're just in a hurry.
Yeah, I
and
think
want
they're
to
just
be-
rushing.
Yeah.
The old story is that they get to do a class on bad handwriting. But,
Oh my God.
the idea, I think, is that some of them, not all of them, some physicians are dumb, but some
be me.
physicians, they're thinking so far ahead
Yeah.
that they're writing down things and they don't stop to think.
Yeah. And thinking about a lot at the same time too.
Yeah.
Like a lot of different things.
But I know that I took a chart to a physician that I worked with, and I looked at it, and I could usually read his handwriting. I worked with him for 20 years, so I could usually read his handwriting. And I just couldn't get it. So I took the chart and off I went, and I knocked on the door and walked in, and he said, yeah. And I said, can you tell me what this means? And he said, what? I said, I can't read your handwriting. Of course you can. You've been reading it for 20 years, you can. I said, no, what? And he looked at it and he did this. I don't know. Take it to Veronica. Veronica was his secretary. So I took it to Veronica and I said, can you tell me please what this says? And she looked at it and said, oh yeah, this means da 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 da. How the heck do you get that out of that? I don't know if that's what because what had happened was they had written it down and then dictated a note to her. And she had just printed it out, so that's how she knew what it was. So I'm sure she couldn't read it either, but anyway. But yeah, so that doesn't happen with an electronic chart, right? And then you have the poor pharmacists who have to look at the prescriptions and say, you know, what is he thinking? What is he writing? And if they get it wrong, whose problem is it? If you take in a handwritten prescription to the pharmacist, and he looks at it or she looks at it and fills it with whatever he thinks it is, and it's the wrong thing, who gets the blame? The pharmacist.
I think now they type it up, print it out, and sign it.
Oh yeah, now they
Usually
do
they
it
send it.
electronically, but it's the pharmacist that causes but it's the physician that causes the problem. So what do? They call the physician and say, I have a prescription for Mrs. So-and-so, please can you tell me what it is? That's what they have to do. And nowadays, they do it electronically. So all things being equal, it should work. And also part of the record and verify system, or the EMR, is a system where you have a drug interaction program that if you write down or the physician writes down a drug and the patient's already on something that doesn't match well with that drug, a flag will come up and say that you shouldn't give this drug because it's contraindicated with whatever drug she's on already.
Birth control, like birth control.
Yes.
Yeah, it's contraindicated with a lot of things now.
Yes, yeah.
Okay, so EMRs allow many caregivers to follow patient electronic reports, provide caregivers with a comprehensive review. Provide collection and storage for information and facilitate the patient encounter by presenting the most relevant information. Non-clinical information, demographics, which we talked about, scheduling and billing. Let's spend a little time, not so much on scheduling. Depending on where you are and which department you are in, billing is handled by certain people. In some departments, it's done by the therapists themselves. In other departments, it's done by a receptionist / scheduler. So they schedule the patients, and if the therapists want to change it, then they change it. And then we have billing. Billing. Does anybody know what the CPT code is? What is it?
The devil's book.
Pardon?
Call it the devil's book.
The devil's book. Okay. So what does CPT stand for? Anybody know?
Something procedural,
Something procedural, something, yes, okay. It's actually current procedural terminology. This is one from 2014, which I was given by the coders. We have a certificate program that does coding. So we have, there's a portion of this CPT code book, you can see the size of it. There's a portion of this code book which handles radiation therapy. And it's under radiology, of course, but there is a portion that says radiation therapy. So it will give you the 5-digit code for absolutely anything that you do with the patient in radiation therapy. I'll give you so we have if we have a radiation treatment delivery, 2 separate treatment areas, 3 or more ports on a single treatment area, and use of multiple blocks up to 5 MeV. Does anybody use 5 MeV anymore? No, we usually use it start at 6. So there's one for 6 to 10, one for 11 to 19, one for 20 or greater. So that would be counted as a complex treatment. Radiation treatment delivery, 2 separate treatment areas, 3 or more ports in a single treatment area. That would be what is called a complex. So that one is for say 6 MV, That's 77408. So if you do that and you put in 77408, then that's what you'll get charged, or what the patient's insurance company will get charged. Here's another one. Radiation treatment delivery, 3 or more separate treatment areas, custom blocking, tangential ports, wedges, rotational beam, compensators, electron beam. This is up to 5, 6 to 10, 11 to 19, 20 and above. So 6 to 10, if you're doing tangential fields with wedges, that's what you would charge. So it would be 77414. So all of these, remember we're talking about stereotactic this morning. Stereotactic radiation therapy, radiation treatment delivery, stereotactic radiosurgery, SRS, complete course of treatment of cranial lesions consisting of 1 session, linear accelerator based. So that would be 77372. And then you have stereotactic body radiation therapy. Treatment delivery per fraction to 1 or more lesions, including image guidance, entire course not to exceed 5 fractions. So that's 77373. And so it goes on and on and on and on. But if you go to the doctor, for example, and you are doing, let me see if I can find something. Oh yeah. If you're doing if you're going in for a bronchoscopy, believe it or not, it's 31626. Absolutely everything that you can have done in the hospital is in this book. And it changes every year. Oh, not every year. So you have radiation therapy treatment delivery, you have radiation treatment management, so what is radiation treatment management? Anything, any ideas?
Is that the once a week visit with the radiation oncologist?
Yeah, that's correct. That's a once a week review by the radiation oncologist. And so the radiation treatment management, this is what the physician has to do in order to earn, or for somebody else to, it's always somebody else, the physician doesn't put it in. This is what he or she has to do. Radiation treatment management requires and includes a minimum of 1 examination of the patient by the physician for medical evaluation and management, for example, assessment of the patient's response to treatment, coordination of care and treatment, review of imaging and/or lab test results with documentation. For each reporting of the radiation treatment management service, the code 77469 represents only the, does not include medical evaluation and management outside of that session. So we also have to review the port films, review dosimetry and dose delivery, and review patient setup. All of that they have to do before someone can actually bill them the code, which is 77427. So you have proton treatment delivery, you have hyperthermia treatment delivery, you have clinical brachytherapy, And you have external treatment planning, medical radiation physics, treatment devices. So if someone makes a block, like an electron treatment block, that can be billed for. If someone uses wedges, that can be billed for. If we're using MLC, that can be billed for. If someone makes a mask, that can be billed for. If someone does a vac lock, that can be billed for. So now you see why in the US, a lot of this stuff is done, whereas elsewhere in the world, it doesn't get done. And I hate to say that, but that's the way things work. Here. So, scheduling and billing services. So, well, we've already mentioned about the scheduling. Who does the billing? Who does the billing to begin with? We do, the radiation therapists do. We do the billing for the treatment that we give. If the cemetery do a plan, then they bill for that plan. If physicists do something to check it, or a special procedure that is done, the physicists have to bill for that. And then everything that is done with that patient per day has to go to a billing service usually. And they double check. And if we do something wrong, then we hear about it. If we do something, for example, if we bill for IMRT and it's only 3D, that's actually counted Medicare fraud. And you really don't want to get on the wrong side of Medicare. You really don't. So, a lot of specialized systems to manage operating processes better and provide improved safety and efficiency. Yeah, okay. How do you get into the EMR? We've done all this before, so you should be able to tell me.
Username and password.
Username and password, okay? So normally the usernames are pretty standard. It's usually your first name and your first letter of your last name, or your first letter of your first name and your last name, or something like that. It's usually pretty standard. And then your password is up to you, but it has to have certain characteristics, like it has to have a capital letter, it has to have a special digit, it has to have up to 1,000 times, and you have to change it every 2 months or something like that. What's the problem with the usernames and passwords?
Writing them down.
Yeah, write them down. Where you actually leave them, the written down ones, where do you leave them? You shouldn't leave them anywhere, right?
Where most people put them like under their keyboard,
Yeah.
on
the
their
keyboard,
monitor.
Under the keyboard, or if they have a desk, it's usually on the top right-hand side of the desk drawer. You open the drawer, and there it is sitting right on inside the desk drawer. You should never, ever leave your password lying around. Never. Because people will use it to get into, do what they should not be doing. And people should have rights in order to do what they need to do. So we would have rights to treat the patient. We'd have rights to go in and make a note in the chart, in the hospital chart or in the treatment chart. We have the rights to look at the images, whether they're diagnostic images or they're CT images or they're our treatment images. What else should we have the rights to do? Depending on the department, you may have the rights to look at blood results. You may not have the rights to actually order blood results, but you should have the rights to look at them. You have the rights to look at the doctor's notes, to the nurse's notes, to the, what they call multidisciplinary notes. So if a social worker has seen the patient, or a dietitian has seen the patient, or a psychologist has seen the patient, you should have the rights to look at all these notes. So there, who else would have the rights to treat patients? Anybody? Would anyone else have the rights to treat patients? No? Yes? Maybe?
Nurses?
Who?
Nurses?
Nurses have the rights to treat patients?
Oh, I mean, no.
No. No, the nurses never have rights to actually treat radiation therapy patients.
Yeah, I'm sorry, I didn't.
Yeah.
Understand that.
The nurses have the rights to look at our charts because they need to see what dose the patients are at, but it's sort of read-only thing. The nurses would have the rights to make notes, make nurses' notes. They may have the rights to suggest treatment, medical treatment to the patient. They probably would have the rights to order blood tests or see a dietitian or a social worker or a psychologist. They would have the rights to do that. What would the doctors have? What kind of rights would the doctors have? The doctors have the rights to do almost anything except treat the patient. Believe you me, they think they know, but they don't. So they would have the rights to do almost everything except treat the patients. The physicist would have the rights to do everything technical. They wouldn't have the rights to do anything as far as the treatment of the patient, but they'd have the rights to work with the machines and the dosimetry and that type of thing. The dosimetrist, what would he or she have the rights to do? Would he or she have the rights to treat the patient?
Adjust doses, I guess.
Pardon?
They would have the right to adjust doses, although They wouldn't do that on their own either.
They would have the rights to, yes, they would have the rights to adjust doses, but only not in the treatment area, only in the dosimetry area.
So they can do that without approval of the radiation oncologist or the physicist?
They'd have to have an order, but they can do it. That's what we're talking about, the rights. They have the rights to do this, but only, the same as we have rights to treat, but we can't treat without the doctors say so, right? So only if, for example, the nurses may have the rights to order medication, but only if the doctor has given them permission to do so. So they'd have to have a doctor's order to do that. Same as we have a doctor's order to treat. The dosimetrist would have a doctor's order to change whatever it is. And usually, to be honest, in most departments, it's a verbal order. And then it's written up later.
What if you have a radiation therapist turned dosimetrist? They have to give up that treatment option if they become dosimetrist?
Yes. You can't double dip, no. If it's a small department where the therapist is also the dosimetrist, then yes. But the therapist has to be a dosimetrist to do dosimetry, because you can't have a therapist doing dosimetry. The dosimetry people will not allow it anymore. They used to be able to do that, but not anymore. So if you are, and nowadays most dosimetry schools expect you to be a therapist for at least a couple of years before going into dosimetry, because they want the experience. They want you to have the experience of treatment before you go into dosimetry. Okay. So, used by many clinical and administrative staff members, therapists, physicists, nurses. Each team member gathers patient information to provide efficient and effective patient care. The compilation of each team's member role produces a radiation oncology record. Typical series of events for a patient referred for radiation oncology. Okay. Benefits in a complex medical environment. EMS, EMR must do the following: be flexible, be configurable, and have codified data that is easily stored. So, EMR has to be flexible. So you want to have the majority of people be able to use it. Say you have 2 treatment machines. You're really lucky that you have 3 therapists on each machine. Wow, 3 therapists on each machine. So each one of those therapists has to have a login and password of their own. Then you have a couple of nurses, so they have to have a login and password. And then you have to have a chief therapist or a lead therapist who has to have a login and password, and her or his rights are more substantial than the rights of the people that are working on the machines. He would be the administrator or the treatment administrator. Then you have a couple of docs who would also have a username and password. And the physicians are notorious for forgetting where they put the passwords. Then you have the physicist and the dosimetrist. Physicists are usually the people who are the administrators of the EMR for radiation therapy. And they're the ones that are supposed to keep on top of people's rights. So a student comes in. Are you going to give a student a right? Some rights. Usually what is done is that you have the listing of all the people that have rights. And at the bottom you have student. And they have minimal rights because you don't want to get screwed up. So you have student rights, maybe you can go in, you can see the patient, and that's really all. You can move the machine around and do some stuff, but you're not allowed to actually switch on the machine, you're not allowed to do this, you're not allowed to do that. So you have minimal rights, but at least you can actually do things, not just stand there like a lemon. Right. And then, of course, you have the administrators, the bean counters, the people who wouldn't all in their accelerator have stood up and bit them, but they're managers of the department or the directors of the department. And they may be MBAs or Masters in Healthcare Administration. They may be nurses. They may have a Master's in Nursing. Heaven help us what they want to do with radiation therapy. Goodness only knows. However, that's the way the world works, unfortunately. So they have to have rights as well. But as far as treatment is concerned, no. They would have the rights to see the patient perhaps, see what the nurses are doing, see what the secretarial area are doing, the billing coordinators, the receptionists, all of those people who also have rights. Okay, input data, keyboard and mouse. Well, okay. Voice recognition systems. Have you ever tried to do that on a computer? It's fun. If you can make them understand them, make them understand you. Barcodes, biometric devices, cameras and scanners, and electronic completion devices. So barcodes. No, we don't barcode our patients. We give them cards. If you're using barcodes, we give them cards. And you go in, the patient comes in and swipes their barcode, and it comes up with their name, and they acknowledge the fact that that's their name, and that's them signed in for their treatment. Or the other way is to come in and say, "Hi, I'm Mrs. Smith, I'm here for my treatment," and the secretary or the receptionist just clicks them in on the computer and they're in for their treatment. Biometric devices, what's that? Biometric devices. Anybody any ideas what biometric devices are?
Fingerprint, eyeballs.
Yeah, retinal scanners, that type of thing. They have been, I don't know whether anybody's seen this, but I think it was in one of the Scandinavian countries that they're actually implanting little scanners in their backs of their hands. It's just a trial. Some bright idiot decided that he'd try it so that he wouldn't have to take his wallet to work. So everything he needs, like his credit card and driver's license and everything, are on this little chip, and they're implanted in the back of their hands. So if they wanna go and get a soda, they just run their hand across and they get the soda.
Isn't that?
Wonder where they got that idea from.
And
Seems very original.
when they come into the building, they have a scanner, so they just run their hand across the door lock, and the door opens, and in they come.
The whole, no,
Hmm?
no.
You don't want a little chip in your back of your hand, do you?
No, thank you.
Okay.
They're gonna know where he's at every moment of his life.
I mean, they already do.
Yeah, it's true, but it's a little different. You can leave your phone, they're gonna cut my hand open, they get a chip out of it. That's like some of the movie shit where you have to like cut behind your ear open and
Mhm.
grab that shit out and throw it like. I could run from my phone.
So, yeah, you can't really leave your hand behind, so, where were we? Oh, yeah. So,
Literally.
to do a note on some of these EMRs or the record and verify. Perhaps Mrs. whatever her name is having had a dreadful night and she was complaining that she was nausea and vomiting and diarrhea and everything all night. So you wanted to see the doctor. So you go in and you make a note. And in some of these areas, you have areas for notes. Nurses' notes, physicians' notes, and as I said before, multidisciplinary notes, which would be ours. And you put a note saying, patient complaining of nausea and vomiting plus diarrhea plus overnight. We'll call RN to assess. So you call the RN and say, Mrs. whatever it is complaining of nausea and vomiting and diarrhea and can you come and see her? So she came, saw her, and she would write a note in the nurse's note saying, saw Mrs. whatever, will call physician to assess. And she signs it and dates it. And then she calls a physician comes, he looks at this lady and says, let's give you better drugs to help you cope with this. And he then writes a note. So all of these notes should be in chronological order, correct? So you do the first note, you sign, you go in and say this is 10:05, and you do your little note, and you sign it and date it. And then the nurse comes along at 10:30 and writes her note and signs it, dates it, or dates it and signs it. And then the doctor comes along at 11 o'clock and does the same thing. So what happens if you go ahead and tell the patient to go have a seat in the waiting room, the nurse will get to you. And you call the nurse, and then somebody else asks you a question and you completely forgot to write a note. And the nurse sees the patient, she writes a note, the doctor writes a note, but you haven't written a note to start the process. What do? The nurse will have written a note saying something like, called by radiation therapy staff, Mrs. has been complaining of nausea and vomiting and diarrhea all night. Assessed, but suggestion to call physician will do, and signs a note. And then the doctor comes along, does his thing, but you haven't actually started that. The nurse has said, called by radiation therapist to see patient. There's no note to say, that we've actually done that. What can you do? It's an electronic chart, remember, so how would you get around that? Or is there a way to get around it?
You just be able to have to put a note in there explaining what happened. What time you did your part.
Yeah, so
Addendum?
would you? Where would you put it? Would you try and squeeze it in before the nurse's note?
I just write it at the end.
Yeah, so you put it, well, remember they have a nurse's note section. And then there's a physician's section, and then there's a multidisciplinary section, which is anybody other than a nurse or a doctor. So it could be the social worker, it could be the dietitian, it could be the psychologist, it could be anybody. So what you would do is you would get to your multidisciplinary note section, and you would put late entry. And you'd date it and the time that you actually did your note, which would be, at this point, it would be noon, for example. But then you would put down at 10:05, called RN to see Mrs. whatever for nausea and vomiting plus diarrhea plus throughout night. And you'd sign it and date it. But you have to put late entry, otherwise it just looks like you've gone a whole cuckoo. Does that make sense? What happens if you make an error? If you make an error in a hard copy chart, how do you fix it? You have a paper chart and you write something and you think, oh no, it wasn't Mrs. Smith, it was Mrs. Brown.
Single
How
line
do
with
you
initials.
stop? How do you, what?
Single line with initials.
Single line with an initial. Okay, so you put a single line through it. Some places you have to put error and you initial it or sign it, whichever the protocol says. How do you do it electronically?
In our old systems, you just had an add note feature that you could add to, you could attach it to that day's visit. So it would pop up anytime you viewed that patient.
Yeah. In most of these newer EMRs or record and verifies, you actually have the ability to put a line through, an electronic line through. So you hit the line through and can mark it through, and then you do what you need to do after that. So, and you put error, initial it, and then put your correct note, and then date it and sign it, or sign it and date it, whichever it happens to be. So you have to make sure, however, that you can read what is underneath the line. You put a line through it, you don't do this. You put one line through it so that it's readable. You can actually read what it said. Okay. Statistics, causes of death, etc., etc., etc. So, image data. So, most of the stuff will go into the system via either electronic imaging, for example, digital cameras. If you're taking a face photo, use the digital cameras, plug it in, and it'll come in. You can put it in the correct area. CT images, they are put in by either the therapist or the dosimetrist or the physicist or the physician. No, not the physician. And what about images from another source? So for example, the patient sees a psychiatrist. She's a little loony, you know? So she goes and sees a psychiatrist, and the psychiatrist sends over his notes. He's outside of the building. He doesn't have a way to put the notes in electronically to our record and verify system or the EMR system. What do you do? So this comes through via fax. They're still using faxes, right? So this note comes through via fax, and you have to get it into the record and verify / EMR. How do you do that?
Scan it in.
Scan it in, yeah, scan it in. Yeah, that's the way that you have to do it, unfortunately. If it's a physician that has rights to get into the EMR, for example, if they're, the doctors who are affiliated with Baptist or the doctors that are affiliated with UF or whatever it happens to be, they have, most of the time, have rights to go in and attach stuff to the EMR, the patient. But if they don't, then they either have to send it by, heaven help us, snail mail or fax.
There's something crawling around in there, very distracting. You can hear it like moving. Keep seeing me twitch like this, it's because I'm waiting for something to fall on me. It's like a bug or something, I don't know.
Where?
In that
In the
light,
light,
I can hear it like moving and scurrying.
Get
Probably
in.
for you.
Oh, keeping me out.
I'm gonna leave.
Okay, as long as it doesn't fall on you, we're okay.
Shit, I'll be the first one
It's
out the
just
room.
distracting.
Send it back to the EMTs, they'll probably deal with it, yeah. Okay.
Or not.
Or not, yeah.
Obviously, you
Okay,
should have said it louder.
user interface. Sorry. What is your definition of a user interface?
It's what we see and interact with on the screen
Mhm.
on our end.
So that's what we term a user interface. Now, some user interfaces are really good. Some of them are pretty lousy. Most of them are somewhere in between. You just have to get used to them. So what happens if, for example, you have your mother calls or your grandmother calls and says, my neighbor, Mrs. So-and-so, is in the hospital. Can you find out how she's doing?
No.
Why not? You've got access to the EMS in the hospital, right? You have access to the EMR in the hospital. Why can't you do that? Pardon?
But she doesn't.
So she's asked you to find out how she is.
There's no way for you to verify her identity. Not the patient, the person on the phone.
Well, she's your grandma.
She
so
doesn't have
called
a need
you.
to know anyways.
Pardon?
She doesn't have a need to know anyways.
Yeah, exactly. She has no need to know. You have no need to know. People have been fired over that. Literally fired. And the hospital gets charged. Hospital gets fined. Thousands of dollars the hospital gets fined. That's why they fire people for doing that. So you do not, one thing is you do not go into anybody else's chart that you do not care for. If it's your patient, then you can find out things about them, although just for yourself and your treatment. Not because Great Aunt Susie is her friend, right? So this is the interfaces. So we have ARIA or Mosaic. They have backups. If the power goes down in the department, they're backed up. They have a server backup in the hospital usually. Or if it's a standalone center, it is usually in another site. And then they have a backup somewhere off-site. And hopefully they have a backup. So you have sort of 3 backups. So if your power goes down, or if the computer system goes down, can you treat a patient?
No,
Hmm?
no.
No, why not?
The generator doesn't generate enough power to run our Linux.
Well, no, it's not the LINAC that's gone down, it's just the computer system.
You can't chart, you can't document anything, you can't,
Well, you can document things
well.
on paper,
Yeah.
that's what we used to do.
You can't access like their previous.
Sorry?
You can't access like their previous
Yeah.
Yeah.
notes and their treatment
Yeah.
plan.
Know what
It
happened
is-
the last time they were there.
It is theoretically possible to do it, to treat. However, you have no idea what the dose is. You have no idea what the field size is because it's all on the computer system. You can actually treat on override, but that's dangerous because you have no fail safes, you have no backups. So yeah, it is theoretically possible, but it is not done because you have no safeguards. You can't use the MLCs because they're computer controlled. You can't use the automatic dose because that's computer controlled, so. You could do an emergency treatment, but that's about all. Because in emergency treatment, you don't use anything as far as MLCs things go. Okay? So, there's 3 of you on the machine. There's 3 of you on the machine. We're splitting through lunches, which means one person goes at 11:30, comes back at 12, one person goes at 12, comes back at 12:30, and the other person goes at 12:30 and comes back at 1. So you have 3 lunch breaks, half an hour each, right? So the person who is running the machine needs to go for lunch early because she was in doing warm-up an hour before everybody else. So she needs to go for lunch first. She forgets to log off. So for the half hour that she is at lunch, they're working on her login and password.
Everybody's messed up.
Now the login and password I'm talking about is the one that goes in and starts the machine up. However, the patients that are treated, you have to do your own login and password in order to treat them. So there's 2 login and passwords that you need to do. And she's one of them. She's sitting in the lounge having lunch. something happens, patient's treated badly or treated wrongly. Her name is on there. Her initials are on there when they type it up to make sure everything's good or not so good. So she's in deep caca, isn't she? Because she didn't log off or log out. So, what?
Caca.
I would have used something else, but that's not polite. Anyway, so what you need to do is make sure that if you go for lunch or go for a coffee break and you've actually signed in, you log off and then someone else logs on. It may sound a bit difficult to do, but it takes half a minute to log off and somebody else half a minute to log in. It's not that bad. And it saves all sorts of problems when, if things go wrong. I'm not saying things go wrong all the time, but the very time that you would do that, Murphy's Law states that things will happen. The patient falls off bed or something like that. Anybody tell me what DICOM stands for? Oh, yes. Okay, DICOM, Digital Imaging and Communication in Medicine. Anybody heard of that name before, or that initials before? DICOM is, has anybody ever used a system which has a server? You know, you're working on one side and somebody else is working on the other, and you're both connected, interconnected by a server. It's that type of thing. So in radiation therapy or in medicine, you have this communication called DICOM. So that when you're putting something in, for example, you're in CT, and you have to move the CT images to the dosimetry to get plans started, that is using a DICOM. You just push the images across using a DICOM. And the images that come from the dosimetry into the treatment area, into the treatment machine, that also uses a DICOM. So that's what the DICOM is. So, information systems, the IT geeks of the department. You have software and you have hardware. The hardware are the machines and the computers. Software is the software that actually works the machines and the computers. And then you have this guy called the network person, called the network specialist. What do they do?
Specialize in the network.
See again?
Specialize in the network. Specialize in networking.
Sorry.
Why do I ask? Okay. So when would they get involved then?
When the network goes down.
The network goes down, or there's a problem with the network. You know, you can get onto the record and verify, but the machine down the hall can't get onto the record and verify. So there's something wrong with the network. So you call these guys who are usually stuck in a room somewhere with no windows. And they don't let them out very much because, you know, they're sort of weird.
Damn.
Sorry. Yeah, most IT geeks, don't say that to the guys here, but most of the IT geeks are a little strange. Nice strange, but strange nonetheless. So you would call these guys and say, look, there's something wrong with the DICOM or the network. Can you please come out and fix it? Well, I can fix it from here. No, you have to come out and see what we're doing. Oh, so they come out of their office. Yeah, I'll come back. I'll go in my office and fix it. So off they go back to the little cubby hole and fix it. And meanwhile, you've got 3 or 4 patients lined up waiting for treatment. Yeah. Systems analyst, okay. Evaluates patterns of information usage and supports the system infrastructure. So, local area network or a wireless local area network. Anybody heard of these two? A LAN or a WLAN? Yes? Okay, good. Wonderful. Okay, so most of our machines don't run on laptops. They have to have desktops. But the physicians may have a laptop in their office. The nurses may have laptops in their offices. Sometimes the review rooms have laptops with the system on it so that they can get moved from room to room to room to room. But the problem with that is that each has to have a license. So if you have 2 or 3 treatment machines, then you have 3 treatment licenses. Then you have a couple of treatment planning licenses. You have a couple of physics licenses. You have a couple of CT licenses. So if 2 people are trying to do, or 3 people are trying to do dosimetry, then they're not going to let one person work because there's only 2 licenses. Does that make sense? In a big department, you may have 8 treatment licenses because you have 7 machines and you want to have a spare just in case. But you have to make sure that you have enough licenses, otherwise you come to a grinding halt. Okay, communication system, wide area network. Telephone dial-up, I don't think so. Okay. This is the brand new, well, not the latest edition too, yeah. Okay, so T1 and T3, do you know what those are? T1 and T3, have you ever heard of those? They're the dedicated lines that the software provider or the internet provider have into companies. It's a dedicated line, nobody else uses it, it's used for downloads and stuff. So the T1s and T3s, or the internet, of course. Stores and maintains application for data and backup systems. Backup systems you have to have, otherwise you're going to have a problem sometimes. Did I tell you the story of the gentleman I heard at Astro last year from Baton Rouge about the backup systems they had? No? Okay, let me tell you the story. This gentleman was from Baton Rouge. He was a chief therapist or is the chief therapist, I guess, and manager in a radiation therapy department in Baton Rouge, Louisiana. And he was talking at the conference I was at in 2019, it would have been. And he was talking about backup systems to the record and verify system. When Katrina hit, although it hit southern Louisiana, New Orleans, that area, it also hit Baton Rouge. So his hospital, well, it wasn't a hospital, it was a standalone center, but his center was completely flooded out. Couldn't treat anybody. The machines were toast. They couldn't do anything. So, and all the patients were being evacuated out of the area. So, a lot of them went to Texas. And they got to Texas, and this guy kept getting phone calls from departments in Texas saying that one of his patients appeared in their department asking to continue treatment. Unfortunately, their computer system was useless. They had no idea, the patient had no idea how many treatments she had had. This happened time and time and time again. They were doing their best, they were quite happy to treat the patient, but they had no idea how much dose the patient had had, how much they were supposed to have, what kind of area they were treating, how big or small or whatever it was, what technique they were using, whether it was a VMAT or just a parallel pair or whatever it was. So, eventually, everything got back to normal, or as normal as it can be in Louisiana. And everybody came back and they got the system back up and running and everything was good. So what they've now done is that they've instigated this system where they buy thumb drives for every patient, big thumb drives, or high capacity thumb drives. And when they do the CT and the planning, all of that was on the thumb drive. And then when the patient starts treatment, the daily treatment goes on the thumb drive. And the patients are given this thumb drive and said, don't lose it. Bring it with you every day and don't lose it. So they actually put little ribbons on them and put them around their necks or whatever they wanted, you know. And every day the patient comes in and they treat them, and then they back up what they've done onto this thumb drive and give the patient back the thumb drive. So that's how they do it. So if this happens again,
I feel like they would be safer kept in the office. I know I would lose it, a string or no string.
yes, but what happens if it's the middle of the night and you're told to evacuate?
I just have this feeling that there'd be a lot lost.
Well, actually, they've been doing this for a couple of years and nobody's lost one yet. Because they tell them that, look, this is your treatment. If you lose it, you'll lose everything if you have to evacuate. So he says they really they don't threaten the patients, but they make sure they understand that if they have to evacuate in future, this has to go with them. So keep it in your wallet, keep it in your purse, keep it wherever, if you carry around your purse all the time, then put it in there. if you're a gentleman, you put it in your wallet or put it in whatever, somewhere where you will not lose it. And it's been working. They say that in the 2 years or 3 years they've been doing this, nobody's lost their thumb drive and nobody's failed to bring it in with them every morning or every day. So it works. And sitting listening to this, and I'm turning around and looking at people and everybody's saying, why haven't we thought of that? That's a great idea. And now the majority of the people in Louisiana, the majority of the departments in Louisiana have started doing this. So, because they're prone to flooding, they're prone to, sorry, you gotta go. Nobody takes chances anymore. And when you consider what happened to Katrina, I'm not surprised they don't take any problems. Okay, so HIPAA. We all know about HIPAA. Passwords and biometric technology. Anybody tell me what the most common password is that people use?
Password.
Password. Yeah. Or even worse, 1, 2, 3, 4, 5. Yeah, the most common password that people use is password. That's why when you're going into the computer or going in, it says you shouldn't use the same password time after time. Some departments will let you do that. I don't think I changed my password I think it was Kentucky. And I changed my password, I was there 3 years, changed my password every 10 weeks, and I used the same password. And nobody thought to change it. Ah, Lord. Anyway, but here, you change it every 12 weeks.
Whatever it is, obnoxious, running out of ideas.
Yeah.
Can't keep coming up with new ones. And then I have like 4 devices that I'm logged into. I have to
Uh-huh.
remind all of them. Drives me nuts.
I know. You'll be like, did you get my email? No. And then I'll go and realize like I haven't
Yeah.
changed my
Maybe the
password in
password on that
Outlook.
device,
Yeah, that's right, yeah. But unfortunately, it's a necessary evil, so you have to do it. Although it seems to come around too often sometimes. But it is a necessary evil, and unfortunately that's to stop people knowing your password and using it to do something that they're not supposed to. And then you get the blame. Have you ever noticed that if you go to a doctor's office and you're talking with the receptionist or whoever it happens to be, and they've got these screens on their laptops or the desktops where unless you're looking straight at them, you can't see.
They have them for cell phones too.
You do they?
Mhm.
Yeah.
Oh, okay. I'll take your word for it.
My friend got one because our supervisor was looking at her phone while she was on.
Okay, yeah. So, yeah, that's one way to do it. The other way is just to log off. Anytime of course, your computer screen should not be visible to the general public. You should never, ever see, the general public should never, ever see your screens. Because 1, you've got all the information on the patient, and 2, you also have the cameras close to the computer screens where people can see the patient on the bed. Now, some departments have what they call countersunk the monitors. So what they do is they have a counter and they put the TV monitors in the counter so that only those who are standing here can see the patients. Whereas it used to be up on here, so anybody came around the corner could see the patient in the room, which is not good. You shouldn't be able to see the patient in the room if you're not meant to. That's why we countersink the monitors. I don't know, I can't remember whether anybody, I think there's a couple of departments now have countersunk, but some of them still have them up on the counters. But that's beside the point. So, most common method of restricting access is the password. So what else could you use apart from your password? Anything in use now that you could use instead of a password?
IDs.
Your ID, okay.
Fingerprints.
Fingerprint, yeah. Anybody use a fingerprint for their laptop? Yeah, I have. One of my laptops has a fingerprint scanner on it. Problem with doing a fingerprint is that it has to be able to, if you're in a large facility like a hospital, you've maybe got a couple of hundred people. So the system has to be able to handle that much technology. So sometimes it's not easy to do. So the username and password is better. And the ID, of course, is the other one. So people, they may not know your password, but do they know your ID number? That's the other thing. If you're off at coffee and you think, okay, she logged in, well, we know her ID number, so we'll just carry on without her. That's not that good either, is it? But, the fingerprint is good, but it takes time. And sometimes, I know my fingerprint scanner sometimes doesn't work and you have to rely on your password. And if you rely too much on your fingerprint, you forget your password. And then you're back to square one again. Yeah. Retinal scanner. Yeah. I don't think anybody's actually started using retinal scanners for logging into the systems yet.
Well, phones have like facial recognition.
Phones have facial recognition, yes.
But if your eyes are closed, it doesn't work, so does that mean it's
Right, no.
It
It is right.
It depends on how, well, no, there's two. There's retinal scanner, and then there's actual facial recognition, which actually works on bone structure and stuff. But the facial recognition sometimes isn't as good as it's made out to be, shall we say?
my sister, sometimes her face works on my phone.
Yeah,
My
Yeah.
phone even has a warning on there when you select that feature, it'll say some people with similar features may.
yeah, well, I mean, if you're sisters, then your bone structure is probably pretty similar, so.
I'll reopen
Yeah.
this tray, it's full. My daughter can hold, not my phone won't recognize her face, but she'll hold her dad's phone and it opens.
Yeah,
But they look identical, so just a female and a male.
That's hilarious.
Okay.
One has hair, pigtails, and he just has hair like this.
okay, yeah, well, that doesn't do much for facial recognition, does it? Yeah. So, the other thing you have to be careful of when you're doing electronic charting is how much training the department is giving you. Because you need to know what the system is all about. There's no use going in to say, okay, I have my username and password, so I get into the system. Now what do? I have no idea how to use it because nobody trained me.
Do you happen to know if the clinical sites all use something different or if they're all pretty similar? Like, since we're gonna be switching every few months, that's gonna be an adjustment.
Yes, and that's what it's supposed to be.
It takes me like 6 months just to get used to one program.
Usually they're pretty similar. Yeah. So even if one uses Mosaic and the other one uses Aria, they're pretty similar. They really are. The systems are different in that the manufacturers are different, but the way things are put in is relatively the same. The screens that you will be using, they're relatively the same. You may not even be using them, so. But you just, you have to get, and this is the same as if I was going in there and I knew Varian and I know Aria, and I walked into a department with Electa and Mosaic, it would take me several days to get used to it. And that's what's going to happen. So you'll get used to it and comfortable, and then move you. And that's part of the training. Because what happens if you have machines, 2 machines? In UF, for example, they have 3 linear accelerators. 2 are Electa, 1 is Varian. So all of the therapists have to know the difference, or have to learn the difference between the software that runs the Varian machine and the software that runs the Electa machine. And they could be the same software, but the machines are different, so the way they use it is slightly different. But that's the beauty of using different machines. And you don't get used to one because 99 times out of 100, if you get a job, it will be using the other machines. That's why I've tried to get you on both sets, because at the moment, I know some of the departments are using Electa and some of the departments are using Varian. So we have to have you at least comfortable on both. Okay, so security. We went through this already, but it bears repeating. Do you want a little break? Okay, 15 minutes then, guys. Back here at 5 to 3. Okay. Oh, excuse me. It says here at the bottom that the radiation therapist has a role and, and responsibility to adopt new technologies. Now, I know that it takes some people longer to get used to new technologies than others, but I can assure you, this field does not stay still too long. The number of years I've been on here, or working in this field, the changes I have seen have been astronomical, to say the least. We worked from no computerization when I started to what we've got now. And once you see the actual, what?
Soon it's gonna be those patients just scan their handshake. By the time we get to your point
Yeah,
of retirement,
who says I'm retiring?
I don't know. You're retired from radiation therapy. Yeah.
No, I'm still counted as a radiation therapist. I still have my license.
But you don't
I'm
work
a
as
member of the
radiation therapist.
ASRT. I'm still a member of the ARRT.
But you don't work as a radiation therapist,
I'm
right?
still counted a radiation therapist, however. I could go in and work, yes.
It's interesting.
Whether I would or not is a different matter.
Do you
But-
like teaching better or no?
What pays more?
What pays more?
Do you like?
Oh, being on the floor. Being a
I doubt this
treatment
pays more.
therapist.
No, yeah.
Yeah, I doubt teaching pays more.
No,
But,
being a therapist on the, in the department where pays an awful lot more.
okay.
But as you will learn sooner or later, money is not everything. Believe it or not, you will figure that out eventually,
Okay.
that money is not everything.
Oh, what was I
You
gonna
have to like what you do.
Yes.
You have to, you know, the old saying about when you love what you do, you never work a day in your life. Yeah. Sometimes we complain and we moan and we complain. But, you know, it's a very, you can't do this job for money. It's just, you have to like what you do. You cannot do this job unless you actually like what you do.
Yeah.
It'll drive you nuts.
That's probably why it pays what it pays.
Oh, yeah, yeah. And that's why we have X-ray techs doing the year-long certificate program because it pays almost twice as much as the X-ray people get, so, yeah. But again,
Oh, you mean the X-ray techs that are switching over to radiation
Yeah,
therapy?
yeah.
Oh.
there is the technical certificate, the specialist technical certificate that we run here, that I run here, is a year-long program, and you have to be either an X-ray tech or a nuclear medicine tech in order to get into this particular certificate program.
How long is the regular X-ray program? The regular-
Same as ours, 2
2
years.
years. So that's like
Yeah.
a whole 3 years then if they wanted to switch over. to
Yeah.
this.
What even is the pay typically in Florida?
For radiation therapist?
For radiation
I
therapist,
think it's like was it 60?
pardon,
Was it like 60? I don't know.
60,000?
Yeah.
Oh, it's much more than that.
Oh,
That's
never
like
mind.
that's like starting out. It's
Oh,
60.
never mind.
Yeah, I mean, straight out of school, I would say 60 to 65,000. Depends on where you are, of course. In California, you make an awful lot more. But then you
Not
have
worth it.
taxes and cost of living there. You go up to the northeast.
New York.
New York,
You-
yeah, I heard those New York, that's.
Yeah, you can get salary over 100,000, but then you've got taxes and the cost of living and stuff. Same with the Pacific Northwest. So it really does, it's a good salary wherever you happen to be. So if you're in Alabama, it's a really good salary for Alabama. It may not be good if you are in California, but for Alabama, it's good.
There's some states where it's over $100,000 a year in some states. Of course, the cost of living there is like
Yeah.
through the roof.
In California, we were making this, the therapists who were coming out of school in California were making 75, 80,000 a year.
If you were to go there, if you were to move there and already have experience, so you'd be making more? Or no?
Probably a little bit.
Probably, yeah, but It depends. They're always looking for therapists in California. They're always looking for therapists in Texas, in the
I
Northeast.
know I was looking, and I was also looking in New York for.
Yeah, well,
I'm from
you
New
know,
York though, so.
yeah. But,
I know I'm living there. I'm gonna live in a shack for $3,000.
yeah, exactly.
$3,000 a month until I
Yeah.
save enough for.
I know that one of my colleagues who actually was from New York, and she was in South Florida with me, and she got an offer to do a 2-year stint in New York. And she negotiated with them, and they were anxious to get her because they were running low on staff. And she negotiated that they pay for her housing.
Oh,
Wow.
that's pretty cool.
Dang.
I was just looking at a travel, they want a travel person to come up to Rhode Island for $2,400 a month. I mean, a week, sorry.
Yeah.
Oh, wow.
Yeah.
It's like $50 an hour, literally.
Yeah.
They said $50 an hour.
That's typical for travel,
Uh-huh.
but then they want you to have at least 2 years' experience before they'll accept you to
It
travel.
said that too.
Yeah. Okay, so let's go back to EMR.
Yeah. I mean, I'm not sure how I would travel, because Audrey.
Okay, EMR. Where's my thing?
They said it would pay for your license in a week.
Okay,
Cherry plants another seed in you.
okay, so
Well, thank you.
SpaghettiOs, here we go.
Oh,
So, EMR, which is a digital version of a paper chart. EHR is a broader data set written by the entire care team. So it's basically everything included in as far as the patient's health record. Personal health record, PHR, is like an EHR, but it's entirely entered and managed by the patient. So if you have a physician that you go to and he or she says, okay, go and get chest x-ray. And they'll write it in the chart, good chest x-ray. So when you get your chest x-ray, you can go on to, if you have a patient portal, you can go onto the patient portal, log in, and sometimes get the result of your x-ray before the doctor does. Sometimes that's a good thing, sometimes it's a bad thing. So, before EHR, after EHR.
They should have put something fun down there in there to replace it.
Yeah. I think a bowling alley would be good. Yeah. Okay, so
Yeah, you're
so what's in an electronic record? So basically everything. Your history and physical, medications you take, the allergies you have, the clinical notes, the vital signs that you have, the scanned documents, and the results and the images. Plus, if you're in radiation therapy, you have all your radiation therapy charts in there too. Now, sometimes the radiation therapy notes or the actual clinical chart is not available for the patient to see. The other thing you have to be careful of when you're doing this patient portal is what your physicians are writing in the charts. Yes, because if you think about what could be written in the chart, like, this woman is a terrible patient. She is totally moody, totally this, totally that, totally that. And then the patient reads it and they think, lawsuit waiting to happen. You know? So you have to be, if you have a patient portal, you have to be extremely careful what you write in your notes. you can say it one way and it seems okay, and another way and patient goes totally berserk. So, patient portal via patient health record. The shared record with your doctor via portal and personal health record that you enter all the data. So it depends on what hospital type place you're in. But your personal record, this is a different thing. So a patient portal is seeing the doctor's notes and the doctor's information that you gave him or her. The patient health record is the stuff that you put in. So you put in your name, address, phone number, your weight, your height, your personal health, physical, that type of thing. And proxy access, consent to see your child's records or elderly parent or spouse. This is where the fun starts. So you are in for treatment. The doctor or the nurse or somebody will say, who do you want to give access to your medical records? Or do you want to give someone access to your medical records? If you say no, then nobody gets access. If you say yes, or who do you want to give access to? Well, my spouse or my brother or my sister or my mom or my dad or whoever it happens to be, and they can get access, but nobody else can. We've had patients who refuse to let anybody get access, which is fine, that's their call. But if there's a problem and we need to call somebody and there's nobody on the list, then we can't call anybody. Okay, clinician, why use an EHR? Well, accessibility, legibility, which is always a good one, alerts and reminders, avoid duplication and increased costs. That's what we're talking about with the two physicians ordering the same imaging. Follow patient preferences, research, and more. So we can put in a script for the pharmacy. We can put in a script for the lab. And the lab get access. And you go up and you say, I have an appointment for my blood to get drawn. And they bring up your name, and sure enough, there's your little requisition saying, yeah, we need a CBC and differential. Patient point of view, shared record with you. Supposedly, why better care? Convenience, continuation of care. But someone, they still has to be the same questions. Yeah, okay. So, better care. How does an EHR or an electronic health record give the patient better care?
I get to see like a detailed whatever you write in detail versus just like having to constantly contact you.
Okay. Yeah, okay. So this one, yeah. But sometimes they still ask me the same questions. Have you ever had that? You've got this EMR and they still ask you the same questions, you know? Do you still have your same insurance company? Do you have this? Do you have that? Yeah, that's it. The software system makes the man skin. Well, that's true. Policy of a healthcare organization, yeah. So every time a patient comes in, you must ask them this. Are you still at the same address? Do you still have the same insurance coverage? Do you still, is your name correct? Da, 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 da. What's your birth date? So, who uses it? Well, like we were talking about, this is CUF, University of Florida Hospital. There's one downtown, there's one in Gainesville. So, you have a surgery center. It's affiliated with the hospital. They use the same EMR or EHR. So the doctor here can write a note and it goes into your chart electronically into the hospital system. So if you go into the hospital and you say, I was treated at the surgery center, you can pull up your stuff. Same with the doctor's office. The doctor's office is, up on Dunn Avenue, that's affiliated with UF. Presumably they have the same EMR that they can contact and see your charts from UF. And you have grandma in a nursing home that's also affiliated with the hospital. And then you can pick it up at home. You can pick everything up at home, supposedly, as long as your network is up. Okay. How does my record move electronically? Well, on a good day, computers talk to each other. Often you need an interpreter. Sometimes the language that people use, the computers don't talk the same language. Basic data set today, growing all the time, what can we share? Why doesn't it always work? Well, standard language and the government program needs to work. It needs to be certified. And if it doesn't, then it doesn't work. If, for example, you're writing a note, or the doctor's writing a note, and the system recognizes certain things, if he uses an abbreviation, which the EMR doesn't recognize, it'll highlight that and say, use something else. There's a recognized group of abbreviations that is recognized by Joint Commission. That's the only ones that people are supposed to use. However, doctors being doctors, they use the ones that they want to use. And when you get your student manuals, there is a list of every known abbreviation known to man. You may never hear them, you may never see them, but they're there. And I can assure you at one time, most of them get used. So, what if my doctor or hospital doesn't use an EHR or isn't affiliated with the hospital that you want to go to? So, copy or fax machine, snail mail. You carry your record. Are you allowed to carry your record from doctor to doctor? As long as it's in a sealed envelope. You're not allowed to send it with you unless it's sealed. Don't ask me why, but that's the rule. You could send it, it's frowned upon, but you could send it through email. But what if you're using a fax machine is there a way to make sure that it gets to the correct person? What's a way to get to the correct person? So you're sending this copy of a consultation with the surgeon, for example. His office is sending it to the radiation therapy department or the radiation oncologist's office. How can the receptionist or secretary for the surgeon make sure that it gets to the radiation oncologist if they're using a fax?
I've always had to call, to make sure they got it.
Yeah, so what you do is before you even send it, you should call. The first thing you mention is make sure it's the right doctor's office to start with that you're phoning. And if it is, you say, can you just clarify what your fax number is? And they give you the fax number, you write it down. And then you go to the fax machine and you put it through and you say, okay, I am sending it now. You go to the fax machine, you type in the buttons and off it goes. And you have said to them, call me back in 10 minutes if it hasn't arrived. And there's also should be a cover sheet on it, right? Everybody remember the cover sheets? I don't suppose many people use fax machines anymore. We don't. It's never very seldom used anymore. And HIPAA. Can you sign up and access your shared medical record? Yes, you can. So is health information always private?
No.
When is it not?
Public health issues, internet.
Pandemic? Yeah, pandemics. We'll just ignore the pandemic for the moment because everything's gone weird with the pandemic. Let's say we're 2 years ago. What would be, there are several instances where you can share health information with somebody else.
We had cases of abuse, there were exceptions.
Cases of abuse, yeah.
Yeah,
What type of abuse?
Child abuse.
Child abuse, elder abuse is the other one. Any other exceptions?
You're a therapist.
What?
You're a therapist.
Mental disorders.
Yeah, so you're
That type of therapist. Okay, you have to specify.
Oh,
because
sorry.
you're a therapist, right?
like a,
Yeah.
just a plain therapist.
Mental
Well,
mental
remember
health
there's-
therapist.
Remember, there's physical therapists, there's occupational therapists,
Not
there's, yeah, okay.
head shriek.
Mental
Mental health
therapist.
Yeah.
therapist.
Okay, yeah. Anything else?
Isn't it like a communicable disease or whatever? Like
Communicable disease, yeah, that's another one.
STDs?
Actually, not communicable, yeah. Yeah, communicable disease. Anything else? There's one more, or a couple more, but there's one specific one.
Yeah, no.
Something involving a lawsuit?
Yeah. A little more specific than that, though.
Yeah, that was very vague.
That's all you got.
Out there.
Yeah. So if you are presented with a subpoena from a judge, then you have to produce the health records. That is the only time that you can do that. So if you get a call from somebody saying that they're a police officer and you want to know if Mrs. So-and-so is there, what do you say?
Come back with a warrant.
What do you say?
I can't give you that information.
Not over the phone.
I'm sorry, I can't say whether she is or she isn't. Can't confirm or deny. Unless you give me paperwork to, in other words, a subpoena actually, would be a warrant. If they're looking for them to arrest them, then it certainly would be a warrant, but, you can't confirm or deny. But if they come in and they have a warrant,
What if the doctor is like, if I take them off this medical treatment right now, they'll die.
mm-hmm.
And then the officer is like, well, I need to arrest them.
Well,
They'll
it
probably wait
depends
till
on what kind of
after.
treatment it is. If it's radiation therapy,
Well,
they can have radiation therapy when they're in jail. They can bring them in every day. Well, I've done that. I've treated people in jail. Not
exciting.
actually in jail, but they've come from jail for treatment every day.
Yeah.
Yeah.
Interesting. That's fine.
And for chemo, they can have chemo in jail. Yeah.
Are we sure that's not just lethal injection? No, I'm kidding. I'm kidding.
Oh my god.
But, yeah, so if they have a warrant, unfortunately, you have no choice. Unless, you know, the physician will say, sorry, she can't move, she can't be moved. That would be, if they were in hospital, then, you know, they just put them under arrest in hospital.
Handcuff you to the bed.
Because I remember treating a gentleman many years ago when we were, no, it was just after I graduated. No, just before I graduated. And we were told that there was a gentleman coming in from Carstairs, which is the Scottish Hospital for the Criminally Insane. And they don't have a centre, if they're found criminally insane,